My name is Dr. Larry Dean. I'm the director of the University of Washington Regional Heart Center, and I'd like to welcome all of you to our University of Washington Regional Heart Center Grand Rounds. Our first case will be presented by Dr. Andrew Frutkin, who's a member of the Division of Cardiology at the University of Washington School of Medicine. Dr. Frutkin.
Thank you, Dr. Dean. I'm going to present a case of a patient that will highlight some of the issues in heart failure management and listing for heart transplantation. 61-year-old man who has ischemic heart failure. An important point is that he's a large man with blood group O. In 1993, he sustained a large anterolateral myocardial infarction. He had rescue angioplasty at that time of his left anterior descending artery. Approximately 3 years later, he had an inferior wall myocardial infarction, at which time he had treatment with angioplasty of the right coronary artery. He shortly thereafter developed severe congestive heart failure. He underwent repeat coronary angiography that demonstrated severe obstruction of his left anterior descending artery, right coronary artery, and moderate obstruction in his trifurcation marginal artery, which was a large vessel supplying his lateral wall. He had a ventriculogram that demonstrated anterior wall dyskinesis and inferior wall akinesis, consistent with his prior myocardial infarctions, and a severely reduced left ventricle ejection fraction of approximately 20%, normal being somewhere over 50%. He had a nuclear medicine perfusion scan that showed viability only in the lateral wall. He had a referral to the heart transplant clinic here at the University of Washington. He underwent a cardiopulmonary exercise test that showed a marginal maximal oxygen consumption of 14.6 mils per kilogram per minute. Approximately a year later, he was listed for heart transplantation as his congestive heart failure symptoms worsened. An echocardiogram in that year demonstrated a still severely depressed left ventricular ejection fraction of around 20% and a markedly enlarged left ventricle with an end diastolic diameter of 82 millimeters. He had repeat cardiopulmonary exercise testing that showed a decline in his cardiac performance with a maximal oxygen consumption of 12.2 mils per kilogram per minute. As time progressed, he had worsening angina. He had a coronary angiogram that showed progression of disease in that large trifurcation marginal artery supplying the only viable myocardium that he had. He therefore underwent a high-risk percutaneous intervention by Dr. Doug Stewart here at the university, where a stent was placed to the trifurcation marginal artery. That was a successful procedure, and he had improvement in his angina and heart failure symptoms for approximately 9 months. However, he had worsening heart failure again. He was admitted for tailored medical therapy in the intensive care unit. This was a transient improvement for him. He was admitted again in February of this year for worsening heart failure. Right heart catheterization demonstrated markedly elevated pulmonary capillary wedge pressures, indicative of poor left ventricle systolic function, and he had markedly elevated pulmonary artery pressures with a very low mixed venous oxygen saturation, again indicative of poor cardiac performance. An intra-aortic balloon pump was placed for refractory angina and development of acute renal failure. Given his large size and blood group O and the long period of time he was waiting transplant already, a decision was made to actually bridge the patient to heart transplant with a HeartMate left ventricular assist device. I'd now like to introduce Dr. Dan Fishbein, Director of the Heart Failure and Transplant Services here at the University of Washington.
Thanks, Andrew. This patient's history illustrates a lot about the natural history of advanced heart failure, our improving ability to support patients with advanced heart failure, the role of cardiac transplantation in the management of patients with this important syndrome, and also the importance of the severe donor shortage that we're currently facing on patient care and potentially on patient outcomes. This morning I'd like to talk about the role of cardiac transplantation in managing patients with advanced congestive heart failure. Heart failure is a big deal in this country. There are about 5 million patients in the U.S. who have this syndrome. There are about 500,000 new cases that occur annually. This is a disease of aging. The incidence doubles with each decade after age 45, and as our population ages, we're going to be seeing more and more patients with congestive heart failure. It is the leading DRG, and it is a surprisingly expensive disease, costing about $5 billion annually. 60% of that money is spent hospitalizing patients for heart failure. Now, not all patients with heart failure have advanced heart failure, but it's been estimated that up to a third of patients who have heart failure have New York Heart Association functional class 3 or 4 symptoms. Unfortunately, there are few randomized clinical trials in this population. We feel that the mortality for this syndrome, that is advanced heart failure, is anywhere in the range of 20 to 50% annually, depending on the severity of symptoms and left ventricular dysfunction. And the syndrome's characterized by recurrent hospitalization and has a profound impact on quality of life. Advanced heart failure really is a syndrome that's characterized by dyspnea or fatigue at rest or with minimal activity, recurrent hospitalization, intense activation of a number of neurohormonal systems, severe diuretic resistance, end organ dysfunction, especially renal dysfunction, an impairment of maximum oxygen consumption, and interestingly, intolerance to drugs that we know are helpful to patients who have congestive heart failure, namely intolerance to ACE inhibitors and to beta blockers. There is ample data to suggest that there is an optimal medical regimen for patients who have this syndrome, and that regimen consists of ACE inhibitors up-titrated to maximum tolerated dose, diuretics, digoxin. If tolerated, beta blockers appear to be beneficial in this patient population, and recently spironolactone also seems to be helpful. There are a number of other therapies that have probable benefit in managing patients who have advanced heart failure. A lot of patients may benefit from revascularization of ischemic or hibernating myocardium, and we now know that we can operate on patients who have coronary disease and severe LV systolic dysfunction with low perioperative mortalities and with the potential to improve left ventricular function and also symptoms. Recently, there's evidence that biventricular pacing may be helpful in patients who have left bundle branch block or interventricular conduction delay, particularly those patients who have severe LV systolic dysfunction and patients who have marked QRS prolongation. There's evidence that this therapy improves symptoms and decreases hospitalization. As yet, we do not have evidence about the impact of biventricular pacing or mortality in this patient population. There's been a trend to hospitalize patients who have refractory heart failure who can't be treated with medical therapy or can't have medical therapy initiated. Patients are tailored in the hospital with Swan-Ganz catheter monitoring, parenteral vasodilators, and diuretic therapy. And there is some evidence that patients with so-called refractory heart failure may not be so refractory when treated with this kind of approach. There is some data that very severely ill patients may benefit from continuous parenteral inotropic therapy in the ambulatory setting. In our own program, we use this kind of therapy for our most advanced heart failure patients, particularly if they have had a defibrillator placed. And there's been a lot of interest in using left ventricular assist devices, especially as bridge to transplant, and there is now evidence that these devices may represent destination therapy. That is, we may be able to treat patients who have refractory heart failure by putting in LVADs and not bridging these patients to heart transplantation. There are therapies that we previously thought were promising, but which we now know are not promising. There was a lot of interest in partial left ventriculectomy or the Batista procedure. We now know from careful surgical studies that this procedure is in fact not beneficial. The same thing is true of dynamic cardiomyoplasty. This procedure does not seem to be helpful in patients with advanced heart failure. And I think that a lot of us are dubious about the value of intermittent as opposed to continuous inotropic therapy. Now, what about heart transplantation? There have been major advances in surgical technique, immunosuppression, infection prevention, surveillance and treatment, and the prevention of allograft or post-transplant coronary artery disease. Following heart transplantation, 85% of patients are functional class 1. That is, they are asymptomatic with respect to symptoms of congestive heart failure, and at least 60% of patients are able to return to work. There's also excellent long-term survival with heart transplantation. We recently reviewed our more modern experience at the University of Washington Medical Center and looked at our last 140 patients who underwent cardiac transplantation, and we found these survival statistics. We have a perioperative survival of 99%, a 1-year survival of 97%, 3-year survivals of 95%, 5 years of 85%, and 10 years of 75%. And clearly, this therapy now offers patients with advanced heart failure excellent long-term survival and an excellent quality of life. This is data from the ISHLT, or International Society of Heart and Lung Transplant Registry, and the bottom line shows the registry statistics from 1982 to 2000 in terms of actuarial survival, and compares our actuarial survival at the University of Washington Medical Center during that same period of time. And you can see that the University of Washington experience with heart transplantation is quite positive. Our results seem to be significantly better than the ISHLT registry data. Now, unfortunately, heart transplantation is not available for all patients who have advanced heart failure. There are only 2,300 or less donors available per year in the United States. Unfortunately, because of the severe organ shortage, 2/3 of the patients who undergo heart transplantation are UNOS acuity status 1 at the time of transplantation. And what this means is that rather 3/4 of the patients who undergo transplantation actually require inotropic support or support with machines to keep them alive at the time of transplantation. As many of you know, there's a hierarchical system in which donor hearts are stratified or given to patients who are at the greatest risk, and inotropic support or support with an LVAD or an intra-aortic balloon pump characterizes high-risk patients. And this really is evidence of the critical donor shortage, that most of the patients being transplanted are actually this ill. In 1999, about 3,500 patients were added to the transplant list, despite the fact that only 2,100 patients were transplanted. 700 patients died while waiting, and the median waiting time for hearts was over 200 days. As of February 28th of this year, 4,100 patients were waiting for transplant, despite the fact that in the next year we expect that only 2,100 patients will be transplanted. This is data illustrating the problem of donor supply and demand. Clearly there is donor-recipient mismatch. These are the patients who have been listed annually, and these are the patients who have been transplanted annually. This large area in yellow are the patients who are not going to receive hearts, despite the fact that they've been added to the transplant waiting list. And this is data looking at the percentage of patients who were transplanted at the time they were UNOS acuity status 1. And as you can see, since 1990, there's been a trend towards transplanting sicker and sicker patients. Again, because patients who are not as sick don't have access to organs because of the organ shortage. Now, heart transplantation, while it offers excellent long-term survival and an excellent quality of life, does have complications associated with it. And these complications include rejection, infection, allograft coronary artery disease, which is the development of diffuse coronary artery disease generally occurring after 3 years of transplant, malignancy, which fortunately occurs in only 1% to 2% of patients after transplant, but can be a lethal disease, and a variety of other complications, including hypertension, diabetes, renal insufficiency, and bone disease. There have been major advances in heart transplantation. From the standpoint of surgery, we've been able to expand the donor pool by using older organs, or rather older donors, donors at a greater distance, donors that have less than optimal or less than ideal heart function. In addition, there's a surgical technique called bicaval anastomosis, in which the superior and inferior vena cava of the donor recipient are sutured together. And this surgical approach improves sinus node function. And we've also used nitric oxide for the perioperative management of pulmonary hypertension, which up until 4 or 5 years ago could be a vexing problem and was responsible for a fair number of the perioperative deaths. Right now, we haven't seen a perioperative death from pulmonary hypertension or right heart failure in close to 8 years in our own program. There have been advances with respect to bridging patients to transplantation. We're now using left ventricular assist devices in a variety of ways. Dr. Bill Curtis will review our experience with this technology in another lecture. But we now use LVADs both as a bridge to recovery, for example, in patients with failed cardiotomy syndromes, or in patients who have acute myocarditis who may get better but need to be supported with devices until they improve. The largest experience is our experience with bridge to transplantation, and there's been increasing interest in using this technology as destination therapy, that is, as a treatment for end-stage heart failure in and of itself. In addition, we've been successful in using continuous inotropic therapy in the ambulatory setting. And right now, about 50% of our patients who are status 1, that is our sickest patients, can actually be managed in the outpatient setting with continuous inotropic therapy, provided those patients have had an implantable defibrillator placed sometime prior to the initiation of this therapy. There have also been important advances in the post-transplant management of patients who receive donor organs. There have been a variety of new immunosuppressive medications, the most important of which have been mycophenolate mofetil and tacrolimus. Interestingly, statins have seemed to play a very important role in both improving survival after transplant and also reducing the incidence of transplant-related coronary artery disease. And there's been a very important development in the prevention of CMV disease, that is the use of the antiviral agent ganciclovir, that both reduces the frequency of viral-related disease and also appears to reduce the risk of developing allograft coronary artery disease. This is some data from UCLA. This was published by John Kobayashigawa, in which patients who underwent transplant were randomized to the statin pravastatin versus placebo and then followed for 12 months. And you can see that pravastatin was highly protective with respect to long-term survival. And this benefit with respect to survival appeared to be largely due to the prevention of rejection with associated hemodynamic compromise. But in addition to which, Dr. Kobayashigawa's group also demonstrated that pravastatin decreased intimal hyperplasia or intimal thickening, and therefore seemed to decrease the likelihood of patients developing allograft coronary artery disease. Similar results were actually demonstrated by a German group using simvastatin, in which simvastatin also conferred a survival advantage compared with placebo, and this group could also demonstrate that simvastatin protected patients from the development of transplant CAD. This is a study looking at mycophenolate mofetil versus azathioprine. Mycophenolate is a drug that inhibits purine metabolism and therefore inhibits clonal expansion of lymphocytes. It's been used as a substitute to azathioprine. This is a study looking at the ISHLT registry comparing patients who survived their initial hospitalization for transplant who either were treated with mycophenolate and cyclosporin versus azathioprine plus cyclosporin. And you can see the mycophenolate population had an improved survival compared with azathioprine. This was not a randomized study, but actually the number of patients who were involved in this study were over 5,000 patients. And now it appears that mycophenolate is highly protective of post-transplant mortality. Some very interesting data from a single-center trial from Stanford, in which patients were randomized to receive either ganciclovir or placebo. And in post-hoc analysis, looking at those patients, it appears that ganciclovir is actually protective in patients and protects them from developing transplant-related coronary artery disease. Now, with that background, what are the current indications for this procedure? In general, most patients who are candidates for heart transplantation have advanced and refractory congestive heart failure, although this procedure is also appropriate for treating patients who have refractory angina or who have recurrent life-threatening arrhythmias. Because of the severe donor shortage and because heart transplantation also has long-term complications, there are general guidelines for transplant candidacy. Patients should have severe symptoms despite an appropriate and aggressive medical regimen. They should have an anticipated poor 1 and 2 year prognosis without transplantation. They should not be candidates for accepted surgical alternatives to transplant, and they shouldn't have comorbid conditions that could have a negative impact on perioperative and long-term survival. These are some of the conventional contraindications, that is, these are conditions which are associated with higher than usual perioperative and long-term mortality and include systemic illness with a poor prognosis, irreversible pulmonary hypertension, although our recent experience with nitric oxide and LVAD suggests that most patients, even patients with severe pulmonary hypertension, can be successfully transplanted. Patients with severe peripheral or cerebrovascular disease are at risk in the peri-transplant period. Active infection, irreversible renal or hepatic dysfunction also represent contraindications. Although we have been doing combined heart-kidney transplants in selected patients, and the results have been relatively good. Patients should not have peptic ulcer disease, severe osteoporosis, malnutrition, diabetes with significant end organ dysfunction, a history of noncompliance, or substance abuse, or a history of psychosocial instability, which would impair post-transplant compliance. I think it's important to note that some of the conditions that we previously thought were contraindications to transplantation have now become accepted or acceptable comorbidities. We transplant a lot of patients who have diabetes, provided they do not have severe end organ dysfunction, and the outcome in this patient population is similar to patients without diabetes. We are seeing patients with a history of malignancy who have been treated with anthracyclines and have anthracycline-related cardiomyopathy. We've been evaluating these patients carefully, and provided their prognosis with respect to their tumor is reasonably good, we've been transplanting these patients with good intermediate-term success. Patients can be transplanted who have chronic hepatitis C, provided they do not have severe cirrhosis. We've been transplanting patients with limited peripheral vascular disease, although still feel that patients with extensive peripheral vascular disease are at high perioperative risk. And we think the pulmonary hypertension is almost no longer a contraindication, given our ability to control pulmonary hypertension with nitric oxide and with the use of left ventricular support. I think it's important that when we evaluate patients for transplantation that we have some sense of what their mortality is at 1 and 2 years. And there have been ways of estimating 1 and 2 year mortality in patients with heart failure. And we look at a number of factors, including left ventricular ejection fraction, functional class, a history of right heart failure, the patient's natural history, whether they've had a precipitous decline in functional capacity or recurrent hospitalizations in the recent past. Markers of neurohormonal activation can be helpful, and measurements of maximum oxygen consumption, which reflect cardiac reserve, have been very important measures to predict outcome at 1 and 2 years in patients with this syndrome. Now, currently, what are the specific indications for heart transplantation? Certainly, patients who are dependent on mechanical or inotropic support are at sufficient risk of dying to justify listing for cardiac transplantation. Patients who have refractory functional class 4 symptoms should be listed for transplant. Patients with severe impairment of maximum oxygen consumption, that is VO2 maxes of less than 10 cc's per kilo per minute, should be listed. We think that patients with functional class 3 and 4 symptoms, despite an excellent heart failure regimen, who also have evidence of severe impairment of maximum exercise function, should be listed. And certainly patients who have recurrent ischemic symptoms limiting routine activity, not treatable with medical therapy, and not amenable to surgical or catheter-based interventions are candidates. Unfortunately, rarely, but occasionally, patients who have recurrent symptomatic ventricular arrhythmias who are refractory to medical therapies and device therapies are also appropriate candidates for cardiac transplantation. With that, I want to summarize that heart transplantation has been associated with excellent symptom relief, improvement in survival with patients with severe congestive heart failure. There have been major advances in bridging technologies and medical therapies that have led to improved outcomes in patients with advanced heart failure. But unfortunately, there are a limited number of organs. We can only do about 2,300 transplants in the United States, and this phenomena highlights the need for new therapies for the treatment of patients who have refractory heart failure. Thank you very much.
Thank you, Dan. I think we have time for a couple of questions from the audience.
Dr. Fishbein, just a quick question. Any role for allopurinol?
It's a good question. One of the things that's been demonstrated at a number of centers, and actually by one of our heart failure physicians, Wayne Levy, is that uric acid levels are associated with higher than usual risk of dying. Right now, I don't think that we know that allopurinol has an impact on either symptoms or survival. It's a very interesting hypothesis, though.
Dr. Fishbein, could you describe the process that is used to decide if a patient is a candidate for a heart transplant?
Yeah. Patients are initially seen in heart failure clinic, and during their initial evaluation, a number of factors are considered. Importantly, we want to think about how severe is the patient's congestive heart failure. Are they sick enough to warrant thinking about listing them for cardiac transplantation? The other very important issue is their medical therapy for heart failure adequate? Could they be treated better with a variety of heart failure medications? And we found that a fair number of patients who were referred for transplant actually can be treated with other or additional heart failure medications and that their symptoms may improve. The third question that's asked is, are they candidates for non-transplant related surgical therapies? Do they have valvular disease that might be amenable to surgical intervention? And especially, do they have coronary disease that might be amenable to either catheter-based or surgical interventions that could improve ventricular function? And the last question that's asked is, do they have comorbidities that would either complicate or preclude cardiac transplantation? Once that initial evaluation's done, if patients need more therapy, their therapy for heart failure is up-titrated, and then they are reevaluated. If they need surgical referral, we refer them to our cardiothoracic surgeons. If they're quite ill, some of these patients actually require hospitalization and a rapid evaluation for transplantation. In the patients who are very ill and who appear to be on maximal medical therapy, we make sure that they don't have contraindications to transplantation. In general, we try and do a cardiopulmonary exercise test. And if that test demonstrates a severe impairment of function, we will then list them for cardiac transplantation after a comprehensive psychosocial evaluation. If the patient may benefit from additional medical therapy, we then up-titrate that medical therapy either in the outpatient setting or in the inpatient setting and reevaluate patient symptoms in the next 1 to 2 months. If they continue to have refractory symptoms of heart failure, we then push on with a transplant evaluation.
And I'm curious as to who is making these decisions as to whether or not they are either indicated or in particular contraindicated.
Yeah, the transplant physician who initially sees, the heart failure transplant physician who initially sees the patient makes the decision about how sick the patient is. Once a patient's evaluation has been completed, they are then presented at a transplant conference, which includes heart failure transplant physicians, cardiothoracic surgeons, social worker, and nurses. And really the committee makes the decision whether or not to list the patient for transplant, and also struggles with the very difficult decision of whether or not the patient has contraindications to transplant. So it's really a committee-based decision.
Thank you, Dr. Fishbein, for your excellent presentation, and I really appreciate the questions from the audience. Look forward to seeing all of you at another Regional Heart Center Grand Rounds in the near future. Thank you for your attendance.